Thank you for inviting me to come and talk to you guys today. I'm very excited about it. I feel like I'm a native Idahoan. I've lived in all 3 states of Idaho. If any of you have lived here long enough or lived in different places, you know that there's 3 very distinct areas to this state. And so I've been fortunate enough to live in all 3 of them. I grew up in eastern Idaho, spent a chunk of time here in the Boise area, lived in northern Idaho in Orofino and Cottonwood area for Clearwater Valley and St. Mary's. Found that I have a conundrum. I'm a city girl who loves rural medicine. So I currently actually do reside in Boise, but I work remotely for Clearwater Valley and St. Mary's and travel up there. So really have learned a tremendous amount about our state and kind of what makes things tick around here. So do I point it here? It's magic. I can just do it wherever I want. Okay. Well, yeah. So I'm going to talk a little bit about some of the things that we've started to do to co-locate medical services in food distribution sites. We were very fortunate to apply for a grant through the Merck Foundation a few years ago. We really didn't think we'd get it. We just decided to throw our hat in. I mean, let them say no, right? Why should we say no? And we couldn't believe we got it. We were shocked. And then we thought, oh my gosh, we have to figure out how to do this now. And so there was a tremendous learning for all of us around this idea of that your social needs, your social determinants really impact your health. And in healthcare, and I feel like I've worked in healthcare a long time, so I feel pretty comfortable saying this, we sort of like it in our 4 little walls of our hospital or our clinic. We kind of like to keep it nice and neat. Not all places are like that, but that is kind of the way healthcare has been. We keep it nice and neat in our place and we provide all the services. Well, suddenly now we're looking at, wow, there's a whole thing out there that we haven't even thought about. And traditionally we have often in our world said, well, that's what public health will do. But now there's this blending of medicine and public health that is occurring that many of us in healthcare are kind of like, wow, what do we do with this? So I'm going to talk a little bit about our journey. We certainly are not there. We have not arrived. We are not experts, but we have learned a tremendous amount, and hopefully something we've done will teach you a little bit about it. So these are our 2 hospitals. Other thing I'm struck with about Idaho is how the majority of our state are these little tiny places dotted all over Idaho. And then we have, Idaho Falls, Twin Falls, Boise, and then, I feel like you don't even get to another big center until you get to Coeur d'Alene. But everywhere I drive through this state as I do it, because my mom lives in eastern Idaho and I drive up north all the time, I am just struck by how rural our state is. So I lived in Boise for a long time, and I live here now again. I grew up in eastern Idaho on a farm, pretty rural area, but I didn't really get rural medicine. I thought I might, but I really, really, really did not. And so until I moved into a frontier area, which I think the definition is something like 1.5 people per square mile. Jackie's nodding her head that that's correct. I mean, it's astounding how far you have to travel to get to services. I just didn't really know that. So the top one, that's Clearwater Valley. And this is where Lewis and Clark came through. You can see in the background the Clearwater River, just the most beautiful place, but very isolated. And then down at the bottom, that is St. Mary's Hospital. So Clearwater Valley is in the valley along the river, and St. Mary's is on the prairie, so it's up and it's agricultural. 2 very different populations, 2 very different environments. It's just really fascinating to work for both of them. Oh, I've got 2.5 square miles up there. So we have 28,000 people in an area about the size of Maine. And so it's not very many people. We have our 2 hospitals and we have 8 clinics. And one of them is in Elk City. Anyone ever been to Elk City? Oh, yay! A couple of you. A couple of years ago, there was a big landslide. And you could not get in or out of Elk City except for maybe twice a day. Once in the morning when a car would lead you out, and once in the night to take you back in because there was just this enormous landslide and you couldn't get in or out. We have one Craigmont, Idaho, Nez Perce, Idaho. I mean, just these tiny, tiny little communities. We are the healthcare services in the area. You really don't have a lot of other choices unless you want to drive far. So Lewiston is the closest. Up by St. Mary's, there's Syringa in Grangeville, so there's a little more option up there. But we are the healthcare provider, and we are really committed to that. That's another thing that has really made me proud to work for these organizations. The amount of commitment to their communities is something that I've actually never witnessed before, so it's very inspiring to me. So an analogy, sort of maybe in the past, it's been that the goalie might have been the primary care doctor who was sort of in charge of it all. I gotta, do all the tests and go know what's going on and be in charge of all your health care. But we've reached a point where that is really hard to do. It's difficult to be one person in charge of somebody. Our world is changing a lot, chronic conditions are changing a lot, and we have to do this in a bit of a team approach. So this is a bit of an old model for us, and we are working hard to change it. Last time I was at one of these, and I missed this morning, I apologize, there were lots of versions of this slide. Did you guys see lots of versions of this slide? You guys kind of get it, that, and in healthcare, we think about ourselves as like, we're it, like we're the thing, but we're like so tiny, we're just this tiny little 10%, and there's so much more that goes on in a person's life that impacts their health. And we in healthcare, we've got to figure that out, and we've got to get on board with that and understand that your time in front of us in the clinic or in the hospital is just a minuscule piece of what happens. And so we spend a lot on healthcare services. We actually in the United States don't see great benefits for the extending life, for all the money we spend on healthcare. We don't actually see that we have better outcomes than other countries. We spend a lot, but we don't always make it better. So our program is Bridging the Gap for Diabetes, and we are tasked with figuring out how to help bridge a gap for patients who are pre-diabetic or diabetic to have a better outcome. And it's not solely around your healthcare needs. It's much broader than that, so it's a big learning for us. So I think you guys have probably talked quite a bit about this, but about food security, insecurity, but we know that patients with diabetes who are food insecure may go hungry, they may reduce their food intake or rely on energy-dense, inexpensive carbohydrates because they cannot get a better food than that. And so we also know they are more likely to be at risk for hypoglycemia, have poor glycemic control, and have diabetes-related hospitalizations. So we are turning ourselves into a team, and it's not just our healthcare people in our clinics or our hospitals. It's not just the nurses and the doctors and the lab tech. It's a much broader team. We have really invested heavily in creating a team that will support patients and address social determinants. So this is who we have. We have behavioral health workers. It's a couple of different people. We have a licensed counselor, and we have a social worker, a master's level social worker. We have nurse case managers. We've had nurse case managers for quite a while. We obtained them originally because of a grant, and they became so valuable that we kept them. So now we have grown that program. So patients who are high need, possibly high utilizers, have a distinct need, variety of things. They are part of our nurse case managers program, where a nurse connects with them and helps them with issues that they have. We have certified diabetes educators. We have a visiting nurse program. We have a registered dietitian. Took us a long time to get a registered dietitian up there. So we are very happy to finally have a registered dietitian. He's really great. And then we have community health workers. Community health workers, anybody, are you guys familiar? Have you done much work or heard a lot about community health workers? A little bit. It's a little bit. It's one of those things that people often say, so what is a community health worker and what does a community health worker do? So we'll talk a little bit about that. But we have a pretty substantial population health team is what we call them. And we created our own department. But first we kind of had them interspersed around in the clinics, and they kind of reported up to the clinic manager and worked kind of with the providers. But we decided we need to bring them all together because we know they're all taking care of many of the same patients. We know they're doing the same kind of work, and we don't have endless resources, so we needed to bring them together. So we have a definite team around this, and they all work together. So community health workers are the thing that I want to kind of focus on today, watching my time. Community health workers I don't know if there's like a solid definition for what a community health worker is or does. I'll tell you about our community health workers. Our community health workers, for the most part, are non-healthcare people. We do have one or two we have one that's a physical therapist. I think we had one for a while that was a registered nurse who was retired. But generally speaking, they are what we call lay people who do not have a healthcare background, and they're from that community. We try really hard to hire people in the communities who are from that community. We've actually seen many people that grew up in those communities, moved away, and have returned to those communities and become our community health workers, which is really satisfying. Because we want them to be a recognized face in the community. We want them to be somebody that people can approach and connect with. We also want them to be a resource and personal contact that is external to the traditional healthcare setting. We have a pretty decent population of people who really aren't very interested in coming in to receive healthcare for a variety of reasons. And so if we just sent a doctor out and said, I'll sit at a table and be here for all your needs, we know that people aren't going to stop and talk to that doctor because they don't really want to. Variety of things, no judgment there, it's just what it is. And so we want somebody who is external to that healthcare setting, so that it's a friendly face. It's somebody who sort of they can connect with and understand, and they know them. And then we want to reach out to those individuals that are not seeking out what you would consider traditional health care. So these are the things that our community health workers do. They do health promotion, education, a little bit of what Ray talked about, that how do we educate people. But they talk about exercise opportunities, health literature, recipes. They do the CDSMP, it's Chronic Disease Self-Management Program, and then the CPSMP, how many letters can they put together, right? It's the Chronic Pain Self-Management Program. They do these classes that help people learn about how to manage their chronic conditions and help manage chronic pain. And they're taught by our community health workers. They're lay people, so they don't go deep into all the stuff around the medicine of it, but they talk about behaviors. How can we manage this in a behavior way? And then another piece that's been really successful for us are screenings and interventions. So we do screening is what we call them, but they are events where our community health workers will go and they set up and they do all this list of screenings for anybody who wants to have them done. They do blood pressure, they do heart rate, A1C tests, they have little finger prick, fit tests, they hand them out, that's for colon cancer. They do a PHQ-2 or 9. The 2, if you're not familiar with that, is just a 2-question one. If you've been to the doctor in the recently, they may have asked you a couple of questions in the last 2 weeks if you have felt down, hopeless, or depressed, and I can't remember what the next one is. If you score positive on that one, then there's another more lengthy one called a PHQ-9. They do BMI, body mass index, and social determinants of health screening to see if they can identify people who might need assistance. For many people, this may be the only place they will receive these screenings because this is the only place that they think that they trust to get them. So I'm gonna back up just one thing. We had one, from a story perspective, we had one guy, I don't even remember what city he was in, might have been Elk City, but he would go to the screenings and he found that he had, I think it was diabetes. He had, or had elevated A1C, but he would not go into the doctor. So this community health worker will give them the results and say, here's what we would recommend and help them find their way into the healthcare system. But this individual said, no way, I'm not going. And so the community health worker just started to give him information, a pamphlet, a resource of some kind, and then they go back to the same places on a somewhat regular basis. Every time they went, he would show up and he'd be tested again. And pretty soon they started to see that his A1C was actually going down, which was pretty cool. And they gave him some more information and he asked some more questions, and they're not healthcare providers and so they're professionals, so they only have so much that they share in their scope, and then came back again and again. I think it happened 3 or 4 times. And over the course of maybe a year, he was really bringing his A1C down. And he got to the point that he felt so comfortable with that community health worker that he then brought his daughter the next time because she was having some health issues and concerns. And so he brought her and they started to talk to her. We don't actually know if they've ever made it into our healthcare system because he was very, he didn't want to give his information. We're like, okay, that's fine, because we're just trying to help people understand where they are and trying to create that connection. And we hope they'll come to see us, from a healthcare perspective, where we want them to be part of our healthcare system because they're a part of our community. But if not, that's okay, but it's still a resource. Otherwise, that man would probably never receive services, period, and who knows where he would be. So it's kind of a nice, I think, story. So how are we maximizing our reach? So we have been doing these screening for years. We've had community health workers for, I think this is our 4th or 5th year we've had community health workers. And we've done lots of screenings, we've been out there, but we kind of felt like we needed to broaden our reach. And the Merck grant that we received really sort of opened our minds to what it looks like for how healthcare might be able to do this. So Cody is our project manager for the Merck grant, and he's fantastic. Usually he would come, but I was able to come today. And I always tell him I'm definitely second string to him. He's really great. He really is passionate about this. So he connected, I don't even remember how he connected with the food bank, but he connected with them. Do you remember, Jackie?
I do. He said that he had gone to Chicago for the Merck grant training.
Mm-hmm.
And there, as they were part of the presentations that the Merck Foundation was providing, we talked about this connection to food banks across the nation. And he said that he and the doctor that were there were like, well, I don't even know what's going on in Idaho regarding the food bank. And he came back and did some things to outreach and connect with us and found out that there's this immense system that we have in place, and we were already doing work in healthcare. So it's been a wonderful partnership and opportunity, but that's how we got connected.
That's great. So it's a great example of how they were like, we don't even know what's going on in Idaho because, well, we're not providing the service, so not knowing. And so it was a great opportunity to say, well, we don't need to provide that service. We are not the experts in food, but we should partner with someone who is and can. So we connected and started to talk about how we might do that. And so the thing that we have started with, and we feel is going well, we are co-locating our screening services and our resource services at Idaho Food Bank distribution events. So our community health worker goes to the distribution event, sets up their screening and their education or whatever they're doing that time. So that as people come through to receive their food at a distribution site, then they can have an interaction. And some of them, first people were like, oh, whoops, I'm gonna lose my little thing. No, they're like, I don't really want to talk to you. I don't want to do that. But they just kept coming because it's just that familiar face, just friendly face. Here we are. And pretty soon started to really have connections. We still have some food sites that, distribution sites that they drive through and it goes in their car and off they go and they're like, they don't get out of their car. There's some challenges, but we've just said, we're going to start here and we're going to see how it goes. So because our community health workers may already be recognized by some of these people because they live in those communities, it has really bridged a gap and they've been able to connect and do some really great things. We've been able to reach patients or people that we would not have been able to reach before. So some of our goals, we want to introduce our community health workers to this whole new group of people in our communities that we may not be connected with. I think in healthcare, we're really good about the people that come in to see us. They come in, we see them, and we know what's going on with them. But there's so many people that choose not to come in and receive services. And it's challenging to figure out how to reach them, to help them identify if there are healthcare needs. And so this has been a really great opportunity for that. We want to increase community health worker access to those less likely to access health care. So a little bit of what I've talked about, referring into healthcare providers and getting them into feel comfortable that this is a safe place. We have lots of programs to help patients if they can't pay and afford care. So. But I think a lot of people just may not know those kinds of things. So we have been able to really connect them, but that's where we continue to go. And then both entities promoting how to embed their work into regional communities. So we started out with kind of a PDSA, Plan, Do, Study, Act. So we are in Plan and Do, and we're getting ready to study soon. So Plan, we wanted to build our robust community health worker program by doing all these services, and having our community health workers meet with food bank volunteers to assess feasibility. So we kind of just all got in a room and said, how might we do that? Like, where are the sites for food distribution? Where are meal sites? What happens to them? What does it look like? How do people come in? Where should we set up? Do you think they'll come and see us? What would be exciting, or what would be interesting? And so just sort of brainstormed how we might do that. So we kind of created a plan and then started going out to food distribution sites and events. And we started to conduct screenings. And like I said, at first it was a little slow, that people didn't always want to participate, but over time people started to participate more and more and more. So the study part of our PDSA is part of our Merck grant, where we are collecting data. So it's all de-identified, so we don't know who these people are, but what we're doing is we're going to be measuring those people who received some kind of a connection, a touch point, if you will, with one of our community health workers. What kind of outcomes did they have? So we may have a first screening. So the screening goes into a program we have called REDCap, but it's de-identified, so we don't know who that person is. Their screening goes in, but they have some kind of a identifier, but we don't know it's Johnny. We just know it's 1, 2, 3, 4, 28, 52. And then we track that one to see later, do they come in again, and are there improved outcomes in any way? So that is a big task for all of our study. So that is we're starting to gather that information, and then we'll be able to know whether it worked. So some of our results, process measures, if you will. So this is kind of the stuff we've been doing. We've had 12 sites visited, met with people in those areas and talked to the organizers. We've had 11 co-location events. So we've been able to go to 11 different spots, and then you can kind of just see the numbers there. 78 screened, and then we have 28 actual referrals that have come about from them. And then some of our successes are those repeat visits, particularly by those who won't see that PCP. They're not interested in coming in. They continue to come back to those distribution events because they know the community health worker is going to be there, and then they can continue on. Another kind of cool success we've had with community health workers that plays into this, they started doing community walks, and around here there's like a walk every weekend, right? You can walk for any cause you want. Well, there, and I wish I had a picture of it, I should put that in the slide. There's this picture of these people walking, and there's snowing. The snow is coming down kind of sideways, and they're walking up on the road because there aren't any sidewalks. It's in the middle of, it's super rural. They're walking up this big road, this hill, and it's just crazy and they're all smiling and they're having a great time. So we've been able to have many, many walks in the communities to get people kind of out and connected. I think it was a little bit of a result of those CDSMP classes. And then we started to have communities jump in and said, we want to help you do this. Can we do another one? And so we've been able to kind of bring people together, because in rural areas, it's quite easy to be at your house and live, back. Your driveway might be a mile, and then you live way back there and not see anybody for days. If you don't go seek people, you will not see anybody. And so that's very common. A way to bring people together, to have like a sense of community, is really important and valuable in a rural area like that. So those are some of our successes that we have seen so far. Things that we know we want to continue to improve on, and questions that we want to answer. We need to include more services at these events. We are working on getting our Cooking Matters program. Ray talked a little bit about that. We are getting ready to put ours together to help people. But we know we need to include some more services at some of these events, or make sure we are able to get people referred into them if they're willing. So like I said, we have our dietitian, our CDEs, those are our certified diabetes educators, our behavioral health, our benefits counselors, to help them with resources. So we've got a lot of programs that we also need to kind of integrate into this in some way. And increase our referrals to CHWs and our food bank distribution sites. So we want to be able to kind of have a two-way referral. So maybe the food bank or somebody at the food bank distribution site or the meal site, whatever that says, hey, there's a community health worker that could help you. And a community health worker they do a lot of great things. They go into people's homes, they help them get resources, they do they might go to the grocery store for them. They're just that sort of friendly person in the community. Kind of like, I guess maybe in the old days when I was young and it was your neighbor that did that kind of stuff for you, right? That's what that community health worker we're really seeing is kind of filling that role. We hope to answer the questions for our study are, do food bank screening events have better attendance? So if we co-locate, do we see an increase of people coming in for the screenings or the food? And either of those are good things, but as a way to boost attendance. And do they result in more referrals per touch than non-food bank screening events? So the ones that we have that are not co-located, do we have better luck with the co-located ones than the other ones? Do we see more people? So those are some of our study that the Merck Foundation is helping us decide and result. So some of our action items that I would sort of encourage you to think about how you could do this. Reach out to local healthcare entities to think about how we could collaborate. And just remember that in healthcare, we kind of sometimes we like to keep it in our little box. And you might have to help them see that you can break out. You don't have to do that. You don't have to provide that service. We can help you in some other way. We have this other aspect that you might not be doing yourself. So you might have to bring them along to think about how they can participate with you. We also know in healthcare, and so I'll share this a little bit, if you're not in healthcare, you may or may not be kind of in the know about this. There's a big movement, a shift in healthcare going from, okay, if you come in and I do test 1, 2, 3, and 4, I can send the bill off to your insurance company or Medicaid and they will pay us for 1, 2, 3, and 4. There's this big shift now over to outcomes. So you can do all you want with that person. You can do whatever you want to do with them, but we're only going to pay you this much money to take care of that person. So if you have good outcomes and take care of that person in a way that really helps them improve, then it helps you financially. If you don't, then you're going to have to come up with the rest of that money. It's a big shift. They call it value-based payment. So they're really looking at outcomes. How are patients doing? Are you able to care for them as a healthcare entity in a way that helps improve their outcomes so that they do better and cost the healthcare system less and improve their quality of life? It feels a little bit like world hunger at times. It's a really big shift for healthcare. We are all in. We have joined a ACO, which is a group of organizations that are doing this kind of work together, and we share ideas, and we're doing all. That's kind of where that population health team came from. We got to really figure out how to do this. We need to understand who our people are, who we're not reaching because they still matter in our community. So there's a big shift in healthcare, and it's hard for those of us in healthcare. If we've been here a long time, it's even harder. For young people, maybe it's not so hard because they're like, it totally makes sense. But those of us have been around a while, it's really shaking our world up, but it's a good thing to do. And then we also, we would encourage you to find ways to work with the local food bank and local experts to become more aware of the types of foods that are being distributed. What kind of options might you get to have if you do things with the food bank that you hadn't done before? So much information. And, I'll be honest with you, I feel like I've been around forever in healthcare, and I'm a little embarrassed to say it, but it's my journey. So I think it is my journey. What can I say? I think I used to be one of those people that said, well, somebody needs food, so you give them food and there you go. Boom, problem solved. No, I have learned so much over this last couple of years around, it's about the right food, because if you've got a diabetic and you give them a box of food that's been packaged for them because you're trying to be super efficient, right, at your site. Let's package all this stuff and hand it to them, and they take it, but there's maybe only 2 or 3 items in there that are good for them, but maybe that's the only food they get, so they're going to eat it all, and it doesn't help their health, but it may help their hunger. And it's just it's a big learning for me personally, and I would say that it's the same thing in a lot of healthcare organizations. We're really sort of opening our eyes. I love Ray's presentation about the food pharmacy and the great stuff they're doing at Terry Riley, and I really hope that we arrive at that place relatively soon, because that's something we're really trying to do, because you have a huge impact as a healthcare organization. But I think there are a lot of people in healthcare that still think in the old way, maybe. And so as you people connecting with them, you might just have to be creative and be patient with them as they kind of start to churn this idea of, oh, how would that look? And so one thing that a lot of healthcare entities are familiar with is kind of this prescription for food, this prescription for food idea. So if we get a prescription for a medication when we go to the doctor, right? Well, they can write a prescription for food, and then they can take it to an entity that would fill that prescription. And that's kind of that food pharmacy idea. It's one variety of it. So reach out to healthcare entities. Figure out how you can help them with their patients, because they have a lot of patients that are in need, and they don't know how to do it necessarily. Nor do they really want to take that on. They're like, oh my gosh, I now have to take on a food bank? I have to be the food bank? Well, no, that you just need to help them see that they don't need to be that distribution site. You have the expertise, you have connections, you have access to a whole other population that could be really beneficial for you to work together on. Are they contributing to the problem by not being able to give great education because they don't have the resources, especially in a rural place? And are there healthier alternatives? All right, I kind of breezed through that because I know I'm short on time. So any questions, comments, any experiences that you've had with healthcare entities? Yes?
So Christine, I might have missed this, and I'm sorry if I did. In your area, did you have a hard time identifying who the community health workers were, or did you bring those people on staff? How did that?
So they are employees of ours. So it was challenging to hire community health workers. I will say that. It's challenging to find people to be the community health workers. It's challenging to keep them. And because we also, the community health worker is kind of this delicate balance of, you want somebody who's part of the community, who's got some longevity in the community, who's familiar in the community, but then they may not stay in the community. So, and plus we have, our population is pretty small. So it's been challenging for us to keep our community health worker fully staffed 100%. But we did choose to hire our own community health workers because there was no one else up there doing that. Now here in this valley, there's a lot of people with community health workers. And so that may not be something you would need to do. You just need to figure out who those community health workers are and connect up with them. And they might just be your best bet because they get it. They're like, oh, they're that bridge between healthcare and the community. So that's how we did it, just because there was no one else doing it. So we took it on. Did that answer your question? Okay. Any other questions, thoughts? All right, we're not experts, but we're in a little bit. I think my contact, mine, and then Cody. Cody's the best. You should call Cody first for sure, but I am happy to chat with you also. Oh, Cody's pretty great. Cody is. So either of us can answer any of your questions about this, and how we're doing it, what we're doing. If we can help in any way, if you just wanted to brainstorm of, hey, I wanted to try that, how did you do it? We're totally happy to talk to you. So call us or email us, and we would be happy to chat with you about how we did it and see if we can help you along, because I think it's a really great partnership. It makes so much sense. So we're happy to talk to you. All right. Yes.
This might be, you are the right person to answer this. So sometimes, Christine, it can be intimidating for us, in the non-healthcare sector to know how to connect.
Yeah.
And who to call. And so sometimes we might be starting at the worker bee level, the folks who are connecting out with the patients in the rural community or those community health workers. How do we get our message into the higher level of the administration at times? How do we work upwards to talk about getting screening started?
Yeah.
Food security, just that kind of stuff. Because that can be hard.
Yeah.
It's a little
Yeah.
You don't know if you're talking to the right person.
Right, and sometimes there are some roadblocks, some walls of, so I think that if you were to call me, I would definitely talk to you. We're a super friendly, open little organization, and so you may not find that in other areas. But I think that, so actually one of the people that I think would be really great if you can talk to them, which may be challenging, is a chief medical officer or chief quality officer, or there might be a chief or a VP, but chief medical officers are really, really vested in having good outcomes for their patients and all the patients in the practice or in the organization. So while that might be a little intimidating, they are one that would really, really help you. So you could use Cody and I to get you connected to lots of people. I feel like I've worked everywhere now in the state, so I might know someone at St. Luke's that I could connect you with. I worked at St. Al's for 13 years. I bet I know someone there I could connect you with. But often somebody at that level is looking at these big initiatives like this. Sometimes if you get to someone like a nurse or a doc, they're just like, whew, they got their head down and they're just doing their thing every day. But if you get somebody who's sort of thinking much bigger on a bigger initiative level, you might be able to find some luck there. Another person it might be really helpful to get into in an organization is somebody like a social worker, or we call them integrated behavioral health specialists in ours, but a social worker, a counselor, somebody like that who's working with patients to help them bridge their gaps in their needs. A case manager, RN case manager might be another person, because they are also doing the same thing. They are making sure patients get their connections made. So that could be somebody who could be really helpful. So those are some ideas that might help you with that. But we're maybe even someone from the foundation. I don't know. If you need any, you can sure call Cody or I, and we can see if we can connect you with somebody for sure. There's a lot of good things happening and some good research to show that this stuff works, and you would actually be helping them greatly. We just have to figure out how to help them see that.